thing. Come bring some kind melodies. Oh, mummy, myself no do pass like this. So many things inside of my gene. Slide down, DBTs.
Good morning. We are starting. Would like you all to please to the front seat, occupy any seat in front of you, so that those who are coming late should be sitting behind you.
just those who can pay for them. And again, no one should be left behind. The second outcome is quality, and that the services not only should be available, but should be of good quality to improve the health of those who receive them. And additionally, the financial risk protection, ensuring that the cost of healthcare does not put people at risk of financial hardship, minimize user fee and out-of-pocket expenditure. These outcomes of the universal health coverage are further emphasized in the Sustainable Development Goals, which Tanzania has committed. And this includes the Sustainable Development Goal number 3.7, by 2030 ensure universal access to sexual reproductive health care services, including family planning, information and education, and the integration of reproductive health into the national strategy program. SDG 3.8 achieve EFC, including the financial risk protection, access to quality essential healthcare services, and access to safe, effective, and quality affordable essential medicines and vaccines. Again, in the UN high-level meeting, EFC Target 5.6 emphasize on ensuring universal access to sexual, reproductive health, and reproductive rights, and agreed in accordance with program action of the International Conference on Population and Background. Today we'll hear from 6 panelists, very extinguished and conversant in this field, and we'll talk about various strategies and examples from the ground. And I would like now to call our panelists on stage. I'll start by calling out for Dr. Chris von German, who is a medical doctor and quality officer at the Ministry of Health, Department of Quality Assurance. He's also M&E specialist with several publications in primary health care as well as quality of care. Dr. German, karibu sana on stage. I would also like to call on stage who is a pharmacist that serves as a dedicated supply chain specialist within the Tanzania Ministry of Health Division of Reproductive, Maternal and Child Health. Mr. Mieye has over 80 years of experience with public sector supply chain management and is deeply committed to enhancing national supply chains, guaranteeing availability of vital RMNCAH commodities to the lifeline. He also possesses Master of Science in Health Supply Chain Management from the University of Rwanda. Machumu, karibu sana on stage. Next on stage in our panel is Adam Rasa. Adam Rasa is a dedicated public health expert, currently serving as a health advisor for ACPO in Tanzania, the British High Commission, Dar es Salaam. He is passionate on strengthening resilient and sustainable health systems for health that are essential to end preventable death and respond to current and future health threats. Adam has worked with ministries of health and development partners in the low and middle income countries in Africa, besides Tanzania. He has also worked in Sierra Leone and supported health programs in Nigeria and Kenya. Adam holds a Bachelor of Pharmacy from Engender University in Dar es Salaam and Masters of Public Health from the University of Cape Town. Karibu sana Adam, a round of applause. Next is Dr. Ntuli Kapologwe, the Director of Health, Social Welfare and Nutrition Services at PORALG. Do I need to say more? Yeah, we all know Dr. Ntuli. Karibu sana, and we are very privileged. Okay, next on stage is Dr. Moke Magoma, our country representative for Engender Health Tanzania. He has extensive experience in result-oriented public health and clinical care, with outstanding leadership for over 25 years. His areas of interest include management and service delivery, including RMNCAH programming, and over the years he has demonstrated experience in planning and implementation of this by various donors, including the FCDO, the British High Commission, ESG, UN, and GIZ. As well, he has also worked for the government of Tanzania. He holds a medical degree from the Muhimbili and Masters of Medicine in Obstetrics and Gynecology from Makerere, and has a PhD in Epidemiology and Population from University of London. He's also an active member of AGOTA. Karibu sana Dr. Moke. A round of applause. So now, the one we've been waiting for to balance the equation on stage is Grace Nyoni. Grace Nyoni is Social Welfare Officer at the Ministry of Community Development, Gender, Women and Special Groups. Grace also has past work as a teacher and a social welfare. She has a bachelor degree in social protection and master's degree in social work. Karibu sana Grace, and we are very happy to have you. Grace is also representing Dr. Nandera Mhando, the Commissioner for Social Welfare, who is today on the same day on Simiyu Siku ya Wazee. So Grace, we are very happy to have you, and karibu sana. So I will start by asking the last person to join the panel a question. Based on the initial introduction that I provided, we talked about equity, and inequity is a major fundamental challenge in actualization of universal health coverage. People with disability, young people, and women face multiple challenges to access services, including and mostly the reproductive and child health services. And that is because on one hand, they have disability, and that might impair their access to service. But again, there are also a lot of stereotypes regarding access and utilization of reproductive health. So Grace, would you share with us what strategies have been put in place by the Ministry of Community Development, Gender, Women and Special Groups to support these groups to access health services, particularly the RMNCAH services? Very good.
Development, gender and special groups are entitled to the rights and welfare of the society, special groups like vulnerable groups such as elderly, children, and so the access to universal health coverage is the right to the according to the special groups like the children under 5 and pregnant woman and free treatment at the hospital. And to see that the social welfare to the national hospital, regional hospital, district hospital are there. To see that all the vulnerable groups are taken care of.
I'm in love with you.
take them the priority to take the treatment on the health facility. Another strategy that there are to ensure that the implementation of national accelerated action investment agenda for adolescent health and well-being (NAIA). This program is multi-sector agenda aimed to empower the adolescent boys and girls to enable them access sexual reproductive health education, HIV infection, teenagers, pregnancy, vocational. And the last strategies are the implementation of the national multi-sector early child development program. The integrated multi-sector program to ensure the children find the adequate care and protection that is the implementation of and we know that the people with disabilities are facing a lot of challenges when they go to post-care health. The government set up the centers for them to access the such as delivered beds to the labor
Thank you very much, Grace. A big round of applause. And thanks to the Ministry of Community Development for these initiatives. As we can see, key things that Grace highlighted. So there is free services, free RMNCAH services on one hand, but there is also the medical insurance cards on the other hand to ensure sustainability. But also, there are policies that exist. And here she mentioned policies and guidelines like the NAIA, which puts adolescents at the center, and all priority RMNCAH services are integrated, as well as the multi-sectoral policy on children. But most importantly, as we also have people with disability in the room, she also talked about infrastructure, the friendly infrastructure. Thank you again, Grace. And now we'll move to Dr. German, the Quality Assurance Officer. And as we all know, critical to the achievement of universal health coverage is quality of care. Because accessing service is one thing, but the quality of those services should be good enough to first improve the health of that person, the community, but also to guide and encourage people to refer other people to that site that can get services in this area. However, evidence suggests that quality of care is still suboptimal, particularly in most low and middle income countries, including Tanzania. So, Dr. Jeremy, as a key implementer from the Ministry of Health, would also like to hear from you what are various quality improvement initiatives that you can share lessons on. What are the innovations that have been put in place, and if you can also talk about the supportive supervision and other quality improvements. Karibu, Dr. Jeremy.
Thank you very much, Rota. Good morning, everybody. As I was introduced, I'm working with the Ministry of Health, Department of Health Quality Assurance. I'm the head of Supportive Supervision Sub-Unit. So I'm here to talk the issue of improving the quality of service, especially of maternal child, especially in the area of supportive supervision. So as you know, the supportive supervision is the key in improving the quality of services in Tanzania and everywhere in the world. So we have supportive supervision has been done in all levels of health service delivery in Tanzania. And as a ministry, we have developed guidelines, and the current one was the one which was developed in 2017 for improving the supportive supervision. But during the implementation, we have some of the challenges, as you know. One of the challenges there was poor coordination in supervisions. You can see some maybe 2 or 3 people going to the CHMPs without knowing if without proper planning. The other one is there is a use of multiple tools. There was no one tool which can be used across the country. And the other one was issue of follow-up of action items which we are always leaving at the facilities. So as a ministry, we have come up with an innovation of digitalization of supportive supervision in the country. So in 2015, on the 15th of September in 2021, we launched digital supportive supervision, which we call it AFIA supportive supervision, to ensure that the supervisions are well coordinated and we can get a real-time data. So after implementation, the system has been used across the country, almost all the regions, and so in the area of maternal child health, we have also integrated the checklists for RMNCAH services in the system, and has been used in several regions. And working with Engender Health, we use the checklist to assess the quality of services in 5 regions of Arusha, Tanga, Pwani, Geita, and Dodoma. Also through the program, the SAF Scaling Up Family Planning Project, we trained the CHMTs and RHMTs in those regions. And last week we trained the RHMT and CHMT in Dodoma region to ensure that they are doing the supportive supervisions in family in the area of maternal child health, also in other interventions in health sector. So that is what we did in to ensure that the supervisions which are done are effective and they produce the desired outcome, and also contribute in reducing the maternal and child mortalities. So what I want to add to you is that for all the implementers or the IPs and DPs to use this system, which we and also to support the training of the CHMTs, RHMTs, and the other levels, so that the supervisions are done effectively, and we can track the trend of the supervision which are done, because using the FSS system, you can see who is doing supervision even right now. You can see the council which are doing. But the good thing is that the follow-up of the action plan, everyone who is going to a certain facility or a council at RHMT, you can also track the action plan which are conducted, and it is easy to make a follow-up if the action plan are implemented or are not implemented. So I want to urge all the IPs and DPs to use the after support supervision, so that we can improve the practice of supervisions in our councils and in health sector in general. Thank you.
Thank you very much, Dr. German. I think the challenges that he mentioned, every one of us working in the field can relate to. And we've always been asking the ministry, please lead us, please guide us. And another thing that, as implementers, we keep saying, like, now the ministry has digitized these tools, and they keep improving, and the ministry is very open to suggestions on where to improve. And here we have been called, all the IPs, all the DPs, can we work together with the ministry to make sure we actually consistently use the government tool on the RMNCAH? But I think would also like to appreciate all the key important messages that you've talked about regarding supportive supervision, the tools, and the role of engaging the CHM teams and RHM teams in supportive supervision and improving quality of care. So now moving to the rest of the panel, primary health care is a driver towards universal health coverage. And that will also support and assist us to improve the coverage as well as advance equity and improving the health system. Primary health care is the whole of government and whole of community. And that combines multi-sectoral policy and action, empowered people and community as well as integrated health system. But additionally, on the other hand, for key health system strengthening, governance, leadership, accountability, financing, and service delivery are vital for universal health coverage. Now to Dr. Ntuli. High-performing and resilient health system built on strong primary health care are essential for UHC and achieving last-mile access of RMNCAH services. Dr. Ntuli is a custodian of all RMNCAH and nutrition service delivery under PRL, but we also know and recognize you through your leadership and exceptional expertise in PHC. Can you please share with us what are the government of Tanzania's efforts to expand access of comprehensive and inclusive RMNCAH services in the last mile? Karibu Daktari.
services were provided at the secondary and tertiary level. But as I'm speaking to you now, we have 790 health centers, which initially were not providing CMOC services, but now they're providing CMOC services. There's even distribution of CMOC services across the country. This country is quite very diverse. It's a very big country, close to 1 million square kilometers, with a population of 61.7 million people. So what we are seeing now with the UN process indicators, those 6 indicators, 4 indicators are performing pretty well in terms of geographical distribution of our CMOC services, but also the access within 5 kilometers is also performing very well. But apart from that, the cesarean section rate is also within the WHO standards of 5 to 15 percentages of all deliveries. So we have done a number of things which we think that if we continue this pace, then at least a Sustainable Development Goal number 3, it might be achieved by 2030. And that's very important. But also there are a number of innovations. We are working with Engender Health, different partners, in trying to make sure that family planning services are available to the women in need. So the unmet need is on decrease. So that's quite very promising. As you know that with the well-accessed family planning, you can avert maternal mortality by 38 to 40%. So with primary health care, having the outreach program, having the mobile services, you can easily reach the women who cannot easily access the family planning methods. And this is a very big plus with the government. But also we have these international and national initiatives, the ENAP, every newborn action plan. Now the government is putting down the number of infrastructure, especially for NQs and other medical equipment to help baby breathe. These are very important things to save the lives of the newborns. But also we have the EPMM, the Ending Preventable Maternal Mortality strategy, which we also adopted from WHO, UNICEF, and other UN organizations. We are also on the verge of actually achieving a number of set indicators within these strategies. But I must say that with all what the government is doing, we cannot underestimate the role of the private sector. We have seen in some of the programs of MMAMA, which is an emergency transportation system, where the government worked with the private sector to make sure that we are using the vehicles which are privately owned to transport mothers and newborn to the healthcare facilities. So all these initiatives makes us think that we need to strengthen partnership and collaboration. We need non-state actors. We need different sectors. For instance, in China, for them to be able to reduce maternal mortality below a single digit, they had one road, one village, one road. And then they made sure that the distribution points for water, safe water, increased. And in so doing, they were able also to reduce maternal mortality. The reason why I'm giving this Chinese example, we need the water sector. We need some other sectors to work with the health sector for us to be able to achieve the last mile safe provision. So this is a quite very important theme that and it relates to the primary health care, and it also relates to the core values of primary health care, which is equity. You cannot achieve the last mile without working on the equity, the issue of solidarity, the issue of community orientation and participation, but the issue of social justice, that primary health care is a human right. Everyone should be able to access primary health care. That's why I'm insisting that primary health care is by the people, for the people, including the women, newborn children and adolescents. So we need to work, all of us, for us to be able to realize that. But apart from that, the primary health care, especially the Tanzanian one, is where we have a very good infrastructure for healthcare financing. We have introduced the direct facility financing in July 2017. Now the capacity of our colleagues who are working as frontline workers is very high. The autonomy is high. They can plan, they can budget, they can implement plan, they can evaluate plan, and also they can inspect whatever is happening at the lower level. So capacitating the last mile vehicle, the primary health care, is quite very pertinent as far as the agenda of Sustainable Development Goal and the universal health coverage. I stop there, and I must appreciate being invited to this panel. It's quite very pertinent and also very related to what we are doing at the President's office. Thank you.
Thank you very much, Dr. Ntuli. you know, as we said, you know, PHC is like your second name. You just don't have a passion for it, but we can actually see on your day-to-day activities, publication, etc. You know, one word that you say that will go with me, primary healthcare is a way of life. It's not just anything, it's a way of life. But key thing that he also mentioned and emphasized is the role of partnership. Partnership with the private sector and partnership with the other sectors beyond health. And I think that really calls for all of us in the way we work. You know, when we go to the facilities, when we go to the communities, when we plan, let's also think beyond what we do. But I think another thing that I truly like from what you say, reaching those who are hard to reach. And that's really a core value of inclusion. We just don't expect them to keep coming to the facilities. What do we do to those who cannot come to the sites? But again, also he talked about the capacity. Let us trust our facilities. The capacity has been built. They have means to do things. Let's trust them. Let's give the power back to the facilities that we work with. Thank you very much, Dr. Ntuli, for those comments. Now, I'll move to Mieye. I think it's a common say, and we've all heard that no commodities, no program. We cannot say we run a HIV program without commodities, RMNCAH program without commodities. And therefore, the role of supply chain in achieving UHC is undeniable. And it's a key foundation to successful healthcare system within a country. So Mieye, can you share with us the overall status of the RMNCAH commodity availability in the country, and what are the strategies to ensure availability and adequate stock of these commodities to the last mile? Karibu Mieye.
Thank you. Good morning, everyone. By starting responding to this question, first of all, I'd like to describe what are those RMNCAH commodities. The RMNCAH commodities are categorized into three groups. Products, tenoid, the RMNCAH commodities are categorized into three groups, which are the family planning commodities, the maternal life-saving medicine, and the newborn and child health commodities. So for the family planning commodities, as per the Ministry of Health guideline, we have approved the 8 commodities. For the case of maternal life-saving commodities, 3, and for the child health commodities, 2. So coming to the question for the overall status of the RMNCAH commodities in the country as of September 2023, for the case of family planning commodities, as you know that the government has set the standard for inventory management for these commodities. At the facility level, they have to stock the stock at the 4 months of stock, which is the maximum stock, and the minimum stock of 2 months of stock. And at the national level, the maximum stock level is 9 months, and the minimum stock is 5 months of stock. So having to say that, for the case of family planning commodities, which are 8, about 5 commodities, we have the adequate stock, meaning they are between 5 and 9 months of stock. For those commodities, example, which we are at adequate stock, are like the oral contraceptive pills, and progestin only pills, we have the adequate stock. Also, the other commodities from the family planning, which we have adequate stock, we have the male condoms, also we have the adequate stock, also the medroxyprogesterone acetate, which is an injectable contraceptives, and also the female condoms. For the case of the understock, meaning that they are below 5 months of stock, we have the implants, both the implant on NXT, the 1 loads, and the 2 loads. We have the stock of the uterine devices. So having to say that for the family planning commodities, just in summary, we have 5 which is adequate, 2 understock, and 1 overstocking. For the case of maternal health commodities, the life-saving medicine, which we are considering here, are 3, which are oxytocin, misoprostol, and magnesium sulfate injection. For them, we are in the safe side because we are within the maximum adequate stock for maternal health.
Apologies, Mie. I see mics have some challenges. If you don't mind, you can come and present from here. Thank you very much. As they're fixing.
So for the case of the child health commodities, we have 2 of them, which are the amoxicillin disposable tablet for management of pneumonia for under 5, and the zinc ORS for diarrhea. So for the child health commodities, the amoxicillin DT, we have the adequate stock, and the zinc ORS, we are understocking. So looking at to the facility where the service delivery is taking place, on monthly basis, we have been doing the analysis through our ELMIC system, looking at what is available to the service delivery points. And at August of 2023, the availability of this RMNCAH commodity overall is at 85%, meaning that at least we are sure that our client, our customer, are getting service. As the moderator mentioned before, that no commodities, no program. So as a government, at least we are sure that our client, our customer, they are getting service to the service delivery points. So coming to the strategies, what are the strategies to ensure the availability of RMNCAH commodities in the country? So we are the government, we are at the driving seat, coordinating all partners to ensure that they align with the strategic document developed by the minister in collaboration with the other stakeholders. For instance, we have this, the RMNCAH, the 1 Plan 3 document, which is a current document to be implemented for all intervention regarding the RMNCAH service. So all partners working with the government have to align with that document so that to ensure we are planning together, then we achieve all the result as one. So from that document, there are several activities or intervention which are to be conducted. Specifically on the supply chain, we are doing supportive supervision, we are doing mentorship and other coordinating committee meeting. So for the case of mentorship, what we are doing is addressing the challenges for the service providers on how to report and request health commodities from the facility. We know there are some challenges, so we are addressing that by capacitating them on how to fill the ledger, dispensing register, And for new staff, we also orient them on how to report and request the health commodity specifically for the RMNCAH service through the system called the ELMIS, the Electronic Management Information System. So at national level, we also have this forum called the Commodity Security Committee, which we are doing it on a quarterly basis in collaboration with different partners, supporting the government on the RMNCAH services. And this forum also has been very fruitful in addressing the challenges of commodity availability in the country. In that forum, we are discussing several issues on the availability of RMNCAH commodities, the issue of funding gap, and strategize on how to address the challenge. We also appreciate the support we are getting also from different partners working in the region in collaboration with the PRAG in supporting this initiative of the commodity security. As currently we have the zonal commodity security meeting. To mention, we have been supported by Engender through FCDO to conduct such kind of meeting, and has been very, very fruitful in addressing the challenge of the last mile stock quality for commodities. So another strategy which we are doing is on the issue of quantification. The quantification, we can just say garbage in, garbage out. If we quantify or we mess up in the quantification, we end up having the expiries or out of stock. So the government also initiated several interventions on that quantification. We are currently implementing the bottom-up quantification where the facilities they are responsible for establishing the requirement. And we have intervention also like impact approach, whereby the councils, facilities, regions are required to ensure there is data driven for decision making in the supply chain initiatives. So another strategies on ensuring the availability of RMNCAH commodities is the issue of financing. The financing is very critical in commodity availability. As we see currently, the government has increased the budget for health commodities up to at least 200 billion per year, and even the disbursement for it has been more than 85%, which is very nice for us in ensuring that the service has been provided to the facilities. Also, to sustain the domestic financing, also the government, through the Minister of Waste, has signed a so-called compact agreement with the UNFPA to ensure sustainable financing for RMNCAH commodities. For instance, for this year 2023, UNFPA contributed like 2.7 million USD, and the government has to ensure that they also contribute with the minimum of 1%, and that has been implemented already by the government by dispersing the 1% as per the compact agreement. Thank you so much. Over.
Thank you very much, Mieye. I think kwanza wote tumekula shule ya commodities and all that. Tukiondoka hapa tunajua systems and everything. So thank you very much, Mieye. And I think another thing that I just want to highlight is the minimum stock. For us, we go to the field and we say out of stock, like out of stock it's already zero. But from here and moving on, we need to know 2 months of stock is the minimum. Like, you know, we're already going to out of stock. So it's important that we all take note of that. But I think another thing that I would just want to, you know, to reflect on is the financing. We see a continuous government commitment in financing health commodities. So the budget as well as disbursement is going on very well, and the compact agreement where, you know, the money which is funded and allocated by UNFPA for commodities, the government is also contributing to that. So for signing that, we know countries have been struggling, other countries have been struggling to sign that and actually actualizing it, but for Tanzania, a progress has already been made. So congratulations. I think we should give a big round of applause to the government for that initiative and commitment. Thank you very much. But that also takes us very well to our next panelist, Adam. You know, as health financing is a core function of the health system that enables progress towards universal health coverage, both by improving effective coverage as well as the financial protection. And development partners use aid as an instrument to assist developing countries to meet their national development goals, including UHC. The role of development partners like the British High Commission towards UHC cannot be overemphasized. As a long-standing partner to Tanzania, can you share with us how the British High Commission is supporting the government of Tanzania to scale RMNCAH services in the lens of UHC? Karibu, Adam.
Good morning. So my name is Adam, Health Advisor with British High Commission. First of all, I must say that ending preventable death of mothers, children, newborn babies is one of the top priorities of British government as a whole, but also at the British High Commission. We all understand that every 2 minutes, a woman is dying either by pregnancy or during childbirth. So we seated here like for 40 minutes now. It means 40 mothers have already died. But also we understand every 6 seconds, a child, a newborn, under 5, or a woman dies every 6 seconds. So that's not acceptable. And the bad thing is 70% of such deaths, they are happening in sub-Saharan Africa. And so as a British government, actually we have something to do to change the narrative. So first of all, I want to congratulate the government of Tanzania. Looking at the data that we see from THS, we see that for the past 10 years, the under 5 mortality has halved, has been reducing for more than a half, which is a good thing. Neonatal mortality has remained almost the same, which means it's an area that we need to work more as a government. But maybe looking at the absolute numbers, it might be decreasing, but still we need to do better there. But also I followed up on the UHI index. We have moved from 38 to 43%, but access to family planning, we scored 63, which is good. Actually, HR for health and the health security, we scored little. That's why we are at 43. So there's a lot that government and partners we are doing to ensure that we are moving in the right direction. So what are we really doing here in Tanzania? First of all, we are supporting a program called Scaling Up Family Planning Program. It has like 2 components. First of all is procurement. We fund UNFPA to procure mostly long-term method for family planning for government. And I think for the past 5 years, we procured commodities worth 64 billion Tanzania shillings. And another component, we work with the partners like Engender Health and Maria Stops. They provide services directly at the health facilities. And the strength of our partners, they work within the government systems. They train the healthcare workers, they do their outreach, they build capacity there. So our belief is that whatever we are doing, we should not do outside the government system. System strengthening is our core. We don't want to do things in isolation. So we support mainland and we support Tanzania, Zanzibar. But also UK, apart from being the second largest donor for family planning, we are also donating through Global Financing Facility, the World Bank, which is funding also family planning commodities. But also, as Dr. Ntuli said here, we cannot depend on one sector to drive changes. So we are also working with the education sector, 89 million pound program that helps young girls to spend 12 years of education. That will help them to become productive members of societies, but also to delay their first pregnancy. Most of these maternal mortalities, they happen for teenagers, all right? So if you give them 12 years of education, automatically they delay pregnancy and good chances to have better outcome as mothers, etc. So we are also supporting education program in Tanzania in that lens. So lessons learned from our implementation, I think I will try to be quick, but I think, first of all, the power of integration. Now our partners, they just don't offer family planning per se. They focus also on screening for HIV, they focus screening for gender-based violence, all right, and they provide support. Actually, when you see the data is very bad, not for Tanzania, globally. For example, 60% of women, they have unconsented vaginal examination. That's a worldwide data. So I don't know for Tanzania, but our programs, actually, they are really integrating that. And when you do integration, one intervention can have multiple outcomes. It is shame for you to go and you just do one thing, you come from Dar es Salaam, you go to my home, Mtwara, I'm coming from Mtwara, and you just do your one thing and you come back. So it's power of integration has made a big impact, I mean, in the health outcomes. But the second thing is coherence. We need to adhere to plan together and work together with the government plans. The good thing in Tanzania, we are part of the sector-wide approach where we sit together, we consult, we make plans together. During implementation, it is very keen that we adhere and we align with the government plans. I went to one facility, I want to mention the region. This region has no enough healthcare workers. One person recruited 5 data entry clerks in a facility where nurses are not enough, doctors are not enough. The government says we need doctors, we need nurses, we need radiologists, but because I have money, I'm going there and I put 5 data entry clerks in a dispensary. So I think coherence, and I'm happy our partners, they are doing that one. I will not talk about joining up with other sectors, Dr. Ntuli has said that, but I think number 4, which I've learned is, I think we need to shift from short-term results, numbers, to long-term impact. When you work with government systems, I'm not promising you that you are going to change things in a single day, but the long-term impact is there. For example, when you strengthen the supply chain, it's not a simple matter, but even when pandemic comes, it's the same supply chain that will sustain outcomes even beyond the family planning. When you train healthcare workers, they will support the wider outcomes. They has brought now. First, now they can manage where they can do some monitoring. It's beyond the you are putting. So I think as development partners, normally we like good numbers. We like, so we can buy results, but after the program closes, nothing happens. So I think we need to take long-term, patient approach because the impact will outlast our program. And final point, our vertical program should also address system strengthening efforts. That is very key. If you get money from Global Fund, do whatever you are doing, but ensure that you have a system approach. If you are family planning, your malaria, ensure that you do you support system-wide improvements. So thank you for listening. Thank you.
Thank you very much, Adam. Thank you very much for the, those comments, and thanks for the support. You know, the second largest donor for family planning, and we see, you know, investment in various sectors. I would just like, you know, to emphasize on the 4 that you've talked about. power of integration, coherence, multi-sectorial engagement, and the short result number should actually focus on the long-term impact. And I think that also takes us very well to our final panelist, Dr. Moke, who will now put it all together. We've heard from various panelists on various sections and departments. Then let's see how it all comes together as one, as a program, as implementation. So Engender Health is implementing a flagship program on inclusive and integrated RMNCAH services, grounded on health system strengthening, which is key for universal health coverage. Again, you are recognized as a credible partner to both the government of Tanzania and donor agencies, as part of the panelists have attested. So with your years of experience and through implementing the Scaling Up Family Planning programs, what lessons can you share with us on the value of integration, integrating various health services within the primary healthcare framework and for enabling more efficient and accessible health services? Karibu, Dr. Moke.
Yeah, thank you, Dr. Anna. What should I say more? Previous speakers have more or less spoken almost what I had. Allow me to do some things.
Dr. Moke, excuse me, if you can come here. I see the mics have started to... IT, please, can you fix the mic?
Yeah, thank you. I was saying, what can I say more than what the previous speakers have said? But allow me to add some few issues. Dr. Ntuli mentioned primary health care for the people and by the people. And with that is ensuring that such services are of good quality or high quality, they are equitable, that is inclusive, and through which available financial resources are optimized. Now, allow me to go directly to the Tanzanian context with the reference to the Scaling and Family Planning. We are generously supported to implement by FCDO. Just a few issues to share. We need, as a country, to increase service oversight. That will ensure that services provided to our people are of good quality, and by good quality we mean are safe, effective, with all the attributes of quality. I think I shouldn't emphasize that. We should ensure that essential commodities are there, and through the Scaling Up Family Planning, we had a small budget to procure some essential commodities for this program, but thanks to the joint efforts with the government, PRAG, Ministry of Health, RHMT, CHMT, and the individual facilities, we have not spent, this is the 4th year of implementation, even a single commodity procured on our part. We have been able to support these facilities, councils, to do redistribution. You find that one health facility may be oversupplied with the one commodity, while the other doesn't. If there is a good oversight to see the stock levels across the councils and whatever, and redistribute, you may misuse available resources to order additional commodities where you could have used the resources for something else. And another critical issue is ensuring that the essential human resource for health is there. We know as a country, we face a critical shortage of HRH. The country has, Dr. Ntuli, correct me if I'm wrong, it's almost, we are lacking 60% of human resource for health we need. And yet, our people need to receive essential services, especially the RMNCAH services. We are managing. They have mentioned that maternal mortality is on downward trend, as well as under 5 mortality. However, the decline in maternal mortality hasn't been as fast as expected. Likewise, we seem to have somewhat stagnated on the newborn mortality reduction. but we know what works. Now, ensuring that we have skilled providers in our respective health facilities is key to ensure this. How do you do that? Improve the skills of the available providers. And this can be achieved through various means. You can do task sharing, task shifting of the available service providers to ensure that much as you have the deficit, services are being provided. And I think we can all attest. When we talk to our friends from outside Tanzania and they tell them we have a gap of almost 60% of HRH, people will say, how is that system functioning? And yet we are seeing the wonderful results we are seeing. As a program for the scaling up family planning, we train service providers, those who lack the skills. We orient them through on-job training, as well as in-class training. And through that, we have ensured services are being provided. And we need to appreciate that at times there is a change of providers within these facilities. We may train someone today, after a year or a few months, that person is transferred somewhere to go and do possibly something else other than the essential services you are doing. And because of that, you need to continuously audit the available skills for you to ensure that you are provided the services. And important to all, my colleagues have said integration of services. We do outreach services where we go to remote areas and serve such communities. If you don't integrate, you may go there and just provide family planning services. But will the need really to that community be only family planning services? No. You will only provide a range of services if you integrate. For the scaling up family planning, we do gender-based violence screening, screening for HIV, and linking those people to available services and support, as well as ensuring that there is inclusivity. We know as we go towards universal health coverage, we need to ensure that our services are inclusive. And notably, we have groups within us, which if we are not careful, we may leave them behind. Our colleagues, people with disability, young people, people from disadvantaged geographic areas, or those who are poor, if we are not careful, we are likely to lose them. For the scaling of family planning, we monitor on a yearly basis even the proportion of our clients who are poor, based on internationally prescribed standards, to ensure that we leave no one behind. And particularly, I need to thank the PORAG and the Ministry of Health. You have been wonderful partners to us, always there to guide us what to implement and to ensure that we implement what is required for a people. And to FCDO, words cannot speak. You have been a wonderful partner to us and to our government. And please convey our appreciation for that support. Thank you.
Thank you very much, Dr. Moke. Thank you for that wealth of experience that you've shared in your lessons. I would just like to reflect on the inclusivity that Dr. Moke has talked about. If you are not intentional about programming for people with disability, for different groups in the communities, the young people, you can very easily have oversight. Like if we ask some of the programs that are here, how many of the people that we serve are people with disability? Very few programs actually track that. How many of the people that you are reaching are actually considered like poor in those communities? Because then you could be doing outreach, but you are still reaching the ones who could have even walked to the facilities, who could have paid for services at the private sector. So thank you very much, Dr. Moke, for highlighting that. Now, without further ado, I'll now move the mic back to the floor for questions and comments. Karibuni. Please raise your hands if you have a question, and we'll move the mic to you, Asante.
Okay. Thank you very much. My name is Odageja. Yeah, the first question from myself is, how far have you been connecting people with disabilities to access your services you are providing? For example, the issue of accessibility to get information. Let's say here in my hand, I have a book, but I'm not yet been in a good position to access what has been written in it. How far, by the way, have you been involving these people to access information? And by the second question is the RHC education by itself. Have you been involving these people through associating their organizations? Because every kind of disability, they are in the PD. Thank you very much for this.
Thank you very much. My name is Ricky Nemo. A couple of questions. First comment is Dr. Moke's observation. We need to improve this oversight. That's so I would also want to sort of chip in and encourage involvement, perhaps, of users as well. So the service users. And this could be done in a number of ways, including using means as social accountability, community scorecards, and likes. And maybe we can get a reaction of what the government is doing about it in a way. Then another question to Pharmacist Muyeye. You've talked about movements in terms of financing activities, but I would like to know generally, or more specifically, where are we in terms of needs versus available budget? What are the needs, current needs for commodities globally here in Tanzania? And what are the approved budgets at the moment? And what strategies then are we using to actually maybe get towards the balancing between the needs and the budget? Thank you.
Thank you very much. Please move to Frederick, and then we'll move to this side. We have a couple of hands from behind there. So if
Thank you.
Please, can I ask the questions to be direct to the point? Thank you.
Thank you. I'm Frederick. Thank you for the nice presentations. I have some few questions, and some of them are comment, actually. Madam, you are talking about the infrastructure, and we see the new constructed infrastructure are taking into account the accessibility needs for people with disabilities. But the challenge, because I've been moving to many places within the country, these infrastructures sometimes, they are not constructed to the standard. You find a ramp very, very steep. A toilet which is meant for people with disability with a narrow door. What are you doing on that? There are measures that you can put in place to ensure that there is a close, monitoring to ensure the infrastructure are really adhering to the international standard. That's one. The second, I think this one is going to be a comment. We know one of the challenge we have with our healthcare providers is lack of skill and knowledge on how to provide inclusive services to people with disabilities. Can the ministry now start thinking about integrating disability inclusive services as one of the topics in the training curriculum for our health professionals, so as to address the challenge? And the last one is on the health management system. The health management information system actually is not clearly capturing the data on disability. I think it's a high time now to review the system and ensure that disability data is captured, because it's very important for planning, for monitoring, and really measuring the impact of our interventions. And lastly, but not least, is during the opening, the minister mentioned the initiative to really train the community health workers for 6 months. I would suggest that one of the topics that should be covered in those training should be on disability and disability inclusion, because these people are working with people with disabilities who are in rural areas, and many times these are the ones who are meeting them and providing services to them. Thank you very much.
Thank you, moderator and the panelists. My name is Joseph Mweshemi from FHI 360. My question goes to Dr. Germana, who is leading the supportive supervision unit. I would like to commend for the great work you are doing in that unit. And as we all know, the ultimate goal of supportive supervision is to improve the quality of services. My question is, I would like to know, do we have long-term indicators which shows us where were we for maybe 1, 2, 3 years, and where are we now? We know supportive supervision is one of the very expensive activity, whereby the government is contributing, the implementing partners are contributing, but are we able to measure really the impact of what we are doing? I will give example. One, are we able to tell the patient or client satisfaction rate of those clients who are visiting at our facilities? How about the clinical outcomes? Yes, we are talking about maternal mortality rate. What about the other mortality rates of the services which we are providing in our facilities in the country? How about the adherence to clinical guidelines? Waiting time, are people able to receive quicker services at the moment compared to maybe 1, 2, or 2, 3 years ago? Issues of infrastructure, staff competence and training, availability of essential medication. I'm happy that Mayeye, you mentioned about availability of those medications, resource management and utilization, also follow-up and continuity of care. In 80s, in our history of health services in the country, in 80s, people, we remember service providers used to follow up clients after treatment on their, for example, the patient has been treated on malaria, they can follow up on the community. Are we able to link that with our community healthcare workers? So I would really love to have a glimpse on if we are making any progress on that. And lastly, on the digitalization of supportive supervision. I'm happy to hear about that. It could be maybe focusing more on facility services. What about the community health services which are provided at the community level? Is it integrated in that system or not yet? Thank you.
My name is Mira, and my question is about the resource allocation with the concern about equity. So how are the resources allocated to ensure that the last minute access is improved without compromising the overall healthcare system sustainability and equity? Thank you.
Thank you, moderator and the panelists. I'm John from UNICEF. My question can be responded to Machumu or Adam, and it's regarding the contraceptive commodities. I'm interested to know the proportion of the government contribution to the resources that we are spending on contraceptive commodities, because we understand recently we have seen funding declining from developing countries supporting Tanzania, and of course many other countries. Thank you.
moderator and the panelists. My name is Dr. Caleb Joel. I work as a system strengthening manager with MST. And as our areas of support, supply chain has always been an issue with ensuring the last mile. So for us to reach the universal health coverage, we need to ensure the last mile is assured. But then the national plans, central pipeline are very good. We heard the numbers from Mr. Mieye that the short term are inadequate numbers. Only implants and Jadel are understocked. But then those which are adequate and understocked are still not available all the time at the facility level for the last mile to access. So the question remains, what are we doing at the lower levels to ensure that the quantification issues, the forecasting issues are actually being curtailed on time? And number two, there's always been an issue with long lead time. Even though the quantification has been done well and the stock is available maybe at the zonos, but then it takes so long time for them to be delivered to the facility for the client, for the patient to access them. What are we doing to make sure we improve that on top of what we've already been doing good? Thank you.
My name is Nyamizi. I would like to direct to the Ministry of Health. Dada Grace mentioned the policy, all child under 5 years get free health services. But for those who need more rehabilitation, I suggested to expand that years until he or she okay. And the last, this rehabilitation service to increase the service of rehabilitation to those government hospitals, especially municipal or even in the ward hospital or dispensary. We believe that this service of rehabilitation will reduce or eliminate totally the disability for child. Thank you.
Thank you very much. Now back to the panelists. Questions and comments. And I think some comments we've just humbly taken them on board, but I would like to start with the ministry to respond to their questions, and then we'll move on. Dr. Ntuli.
Thank you very much. We had a very good question. Maybe I'll start with the issue regarding the resource allocation. The formula which we are using right now is taking equity into account. So we have resources that are directed to the district, and there are factors which we are considering there is a population size of the respective districts, then the land captive factor, the under 5 mortality rates, the poverty index, and the hard to reach. So we have added hard to reach because there are some of the district councils which really had. One of the examples is the Ukerewe, where we have 38 small islands within Ukerewe. So you need to have a special formula for that particular district. Then we are done with the resource allocation formula. We go to the facility, and there are factors which we consider there. We have the service utilization rate, we have the catchment population, and also we have included the number of indicators which are maternal related indicators, and OPD and the IPD attendance. So in so doing, we believe we take into account the issue of equity. And then going to a question which was asked by Dr. Mweshemi, indeed, we take into account the issue of community healthcare because the community healthcare system is an extension arm of the primary healthcare. It is embedded within the primary healthcare. Tools which we have right now, we can capture the community, but we can capture the facility as well. So there is no challenge at all. We have distributed number of tablets to the community healthcare workers, and we have the main server at the Ministry of Health and the President's Office, which has all the information from both the facility and the community. Then with regard to the question which were asked by Frederick, I take them as comment for a government to go and work on. But I must tell Frederick that before 2017, we didn't add any plan for accommodation of the facilities for people with disabilities. And we are very grateful for a number of associations for people with disabilities who we worked with in making sure that we come up with drawings which will be accommodative for the people with disabilities. So the issue of social inclusion is seriously taken by the government of Tanzania. But I also must admit that you go to some other facilities where you find that the steepness of the ramps really, you find maybe there's some technical challenges and other things. So we take all these comments, including the issue of health management information system, and also the most recent are taking the module for people with disability, sign language for the healthcare providers. We have already submitted to the Minister of Education to make sure that the healthcare providers, especially frontline healthcare workers, they should be capacitated other things so to attend this. Colleagues respond.
And we appreciate for all the comments, questions. We know we might not be able to answer everything here, but we just hope you'll keep the conversation going. Thank you. Okay. So we start with Mie, yeah?
Thank you all for your good question. To start with, I just start responding to the last question about what are we doing to ensure the availability of the RMNCAH commodity at last mile. Several interventions we have been doing to ensure the RMNCAH commodity at the service delivery point where service is taking place. First of all, we are doing the mentorship of service providers, including that during and reporting they are not seeking any RMNCAH commodities. That is one of the strategy we are doing, the mentorship on the management of RMNCAH commodity. The other thing is the redistribution, especially when they are having the overstocking, and we ensure that we are distributed it to the facility, the out of stock. The ELMS system, the high currently, because people sitting at national level, district level, or regional level can be able to see the available facilities to ensure that the commodities are available at the service point of the. So coming to the question of the proportion of the what is the government is supporting on the procurement of contraceptive commodities, we understand the very big contribution of government with covering all the storage costs for commodities and also the distribution being covered by the government. As I mentioned it before about the issue of the compact agreement, the government is contributing the 1% of what has been supported by UNFPA. I just mentioned it a few, but it's a lot of contribution. I have not have exact number for now, but the government is contributing a lot on ensuring these contraceptive commodities are available at the service delivery point too. So also appreciate the supporting from ensuring the availability of this contract.
Asante sana. Najua bado Dr. German ana maswali ila nitaomba, we would like to respect time. We are at 0. Hatuja over, we are at 0, so we would like to just use this opportunity kuwashukuruni nyote for attending this session, and heartiest appreciation to our panelists for very good insights. And thank you all. Karibuni sana. Keep the conversation going. Thank you. A big round of applause, please. Asanteni sana, asanteni sana. Tunaomba group photo. If you can just have a quick group photo with the panelists. A group photo. Naomba mshuke kwa hapa chini tupate a very nice picture. Asanteni sana. Lakini pia kwa sababu tumebarikiwa kuwa na makundi maalum, nitawaomba kama pia mnaweza mkajoin hii picha. Asante. Pictures please. Haraka haraka. Asante, asante. Asante. Karibuni, karibuni. Tunawashukuru sana. Engender Health Team, please, you can also join the picture. Asanteni sana. Freddy, karibu. Asanteni sana. Tunawashukuru sana for participation. Tunawashukuru for contribution. Thank you very much. Tunashukuru tuna vijana. Scaling Up Family Planning Team, tafadhali. Dr. Kinema from Pathfinder Team, tunaomba mjoin. CCBRT, tunajua mpo. Asanteni sana, asanteni sana. Our partners, thank you very much. Anapiga pale. Asanteni
Please do not
sana.
leave the room. THPS forum is next.
Asanteni sana.
Thank you very much, Engender Health. You also kept time.
Thank you very much.